and women are treated certainly like a second-class citizens.
Yeah.
Girl disappointed, they want a boy. And first of all, and then also if the girl is not fair, oh, she's dark, that's another issue.
Draupadi is actually
Very-
supposed to be very dark.
Yeah.
She has Krishna
But
Varna. But
nobody-
then they want to portray it as the most fairest woman.
The GDP India and China were same. GDP of China today is 19 trillion. India is 4. Why can't we do, man?
So do you think the think tankers at the government, whether Niti Aayog or any other organizations,
They
are
are all-
aware of this fact?
Our doctors who work in AIMS and other areas, what do they know about private?
Yeah.
Zero. The system has to be dismantled. Where I see the problem in Indian healthcare today is the trust is not. So they expect doctors to not make any money and live a very altruism life of all this training, not have any aspirations. It's not possible. That's why I tell my doctors, if you drive a nice car, if you're doing good, we have no issues.
But there is a socialistic mindset,
Yeah.
a country like India.
And I told the farmer, look, there is this hospital close by. Why don't you go? He said, no, sir, I want here only. So then, of course, because I was involved, I told him, you can't sell your property, do anything, borrow loan. We took a statement from, helped him from the foundation. Who is responsible for this? Is the farmer responsible? Is the HCG or hospital responsible? Or is the system who is responsible?
Hello and welcome. Today we have the incredible honor of hosting a true pioneer in global healthcare, someone who has not only transformed cancer care in India but has also inspired change through his visionary leadership and compassion. A globally trained oncologist, Doctorpreneur as he calls himself, author and philanthropist, he has dedicated his life to making world-class healthcare accessible to all, especially in marginalized communities. From founding Healthcare Global, India's largest network of cancer centers, to championing rural development and women's empowerment, his work has touched countless lives. Please join me in welcoming the remarkable Dr. B.S. Ajaikumar. Dr. Ajay, welcome to the podcast.
Thank you, Aditya, for inviting me.
Yeah, it's been such an honor, privilege, and also in a way victory for me to have you here and me hosting. Thank you so much.
Thank you again. Thanks a lot for having me.
Sir, in today's conversation, we will be speaking about two critical themes. The first one is the current state of Indian healthcare system and also the deep-rooted structural challenges that it faces, and also how policies can help, address those issues. And the second thing is about your favorite topic as well, docpreneurship, where we want doctors to venture into technology, innovation, and become entrepreneurs so that they can address and mitigate the missing gaps that we are going to identify during this podcast. Now, sir, you have always spoken about this value-based healthcare model. And one of the concepts is affordability without compromising quality. You have always advocated about that. But what we see is largely this is very critical for the underprivileged section of the society. Now, I would like to state some facts. You already know it. For the benefit of the viewers, I just want to read out some statistics where 65% of India lives in the rural areas and only 25% of the country's overall healthcare infrastructure serves them. The doctor to patient ratio in rural areas is 1:11,000, which is far below the WHO recommendation, which is 1:1,000. Now, out of pocket expenditures also remain alarmingly high, pushing around 39 million Indians into poverty line. Sir, we have come a long way. Why do you think even after 75 years of independence, we are still seeing this kind of disparity? And what can be done in terms of policy perspective to enhance better healthcare for our citizens?
See, Aditya, the healthcare for any country is a big issue, and priority is very important. After having lived in US for 28 years, practiced there, United States spends 19% of their GDP on health.
19.
19%. Okay. And some European countries spend lower teens, some of them spend 10%. But in India, we spend only about 1.5%. In terms of dollars, when we look at it, United States spends over $10,000 per person for health. Most of the European countries spend around 4 to 5,000 euros. China spends over 500.
Okay.
India spends somewhere around $75 to $80 per person. So, unfortunately, prioritization of healthcare has not happened for various reasons. Even when you take, for example, prevention of a thing, people talk about it a lot. But how much emphasis we give for prevention? One of the good positive things is, for example, in women, certain diseases like cancer of the cervix are coming down because of the certain hygiene factors they have taken. As they become more educated, move up the ladder, they have become more hygiene oriented, and that has brought down the human papillomavirus. So there are good things which have happened that way. But the question is, main question is, how do you bring about high quality of care across India? India is 1.4 billion population.
Yes.
And it is like a multiple countries within a country. I always like to say, we have affluent India.
Yeah.
But population may be good by some standards, 200 to 300 million, which is almost equal to United States population or entire Europe, which is getting good healthcare. So maybe we should first talk about what is good healthcare in this affluent India, and why, in a way, we should be proud of it before we address the other issues. Okay? So when we look at the upper class, middle class, the quality of healthcare, I can tell you, having practiced in US and been in India for 25 years, for the type of money we spend, the type of quality of care we get, the affluent section, upper middle class, is phenomenal. For example, you take somebody wants to get a knee surgery done. In the US or in Europe, you have to wait months together. In US, maybe a month or so. In Europe, 6 months or so. Whereas in India, it can be done in days. You go to a corporate hospital, they say you have knee problem. Within few days, the doctor will operate. And they are also concerned they may lose the patient. They do it quickly. And quality is very good. Outcome is very good. And cost-wise also, it is almost like maybe 1/4 the cost of what it costs in US. Definitely at least half the cost it costs in Europe. So the people, and 77% of healthcare in India is by private. So when you look at all that, private enterprise providing this service is phenomenal. For example, you take cancer, which I am involved in. Suppose I see a patient, let us say on a Monday, comes with a diagnosis of suspected cancer or cancer. By Thursday or Friday, literally, I can do all the scans. I can do the pathology review, all the tumor boards, and start the definitive treatment to the patient by Thursday or Friday. Nowhere in the world it happens.
Yes.
Sometimes what we have in our own backyard, we don't appreciate. And also the system, when you talk about government, the system, are so engrossed in the cost, they forget what kind of high quality care we are being given. So when it comes to cost, you should always tie up cost with outcome. None of the Indian systems so far tie up with it. So the value-based medicine, when we talk about, is truly a way to measure. Suppose we did a study which was a Harvard Business School case study 5 years in a row. Suppose we spend, let us say, $25,000, $30,000. Suppose we spend 20 lakhs. What is the outcome of treating a breast cancer, which happens in US or Europe, compared to spending 5 lakhs or 6 lakhs? What is the outcome? What we've shown about 10 years ago was that was the cost at that time. The outcome is the same at this low cost.
Right.
So that is truly value-based medicine. You cannot say, look, I am doing a service for 30,000 and get a poor outcome.
Right.
Okay?
Right.
And that is the problem when you look at all the schemes and all that. So for a minute, let me talk about the schemes and bring it back to the first. People tout the schemes, government initiative, which is good. But unfortunately, these schemes really do not cover all the procedures, all the things. While the patient may feel, unfortunately, they're getting all the treatment, they're not getting the optimum treatment. So what happens because of that? Recurrence rates are high. People come back with disease, and the doctor has to wonder, what did I do here? I couldn't give the right treatment for the patient. So this discussion we can have in an elaborate way, but I just want to leave the thought process for people to think about it. Those who think the schemes are optimal or not. The schemes are, as I call it, half-baked. So leave that aside, come back to the high quality of treatment we provide. So today people walking into, let us say, HCG Center, Bangalore. We have 25 centers across India. Let's take Bangalore example, Center of Excellence. I can say without any question or doubt that they're getting the same kind of treatment what they would get where I trained, MD Anderson, one of the biggest centers in the world in Houston, pretty much same treatment. And outcome which we measure are the same. So it is very important to understand that as a doctor, my focus is not only on the cost, but more than that, we should be more concerned about the outcome.
Right.
Okay? Am I giving the same outcome in what should be in 2025?
Right.
Okay? Can I even better it? For example, in our tumor board, when we see a patient, when we say, okay, you have cancer of the lung or breast cancer or tongue cancer, first thing we wonder is, based on the current treatment, what is the outcome for this patient? If there is a 90% chance that will not come, it's great, the treatment. But whatever I am doing, whether it is financial constraints or lack of technology or lack of knowledge, if the outcome is going to be 30% only or 40%, then something is wrong. Maybe I'm not delivering the right thing. So you have to question, go back to the drawing board and say, how am I going to improve? There comes a time when, of course, in like any other diseases, we have to say at some point we run out of treatments. Well, that happens. Any disease it happens.
Yeah.
So also happens in cancer.
Yeah.
But the important thing here is what I always say, first time right treatment is important. Whether the patient is affluent, whether the patient is middle class or lower socioeconomic class, cancer doesn't know.
Yeah.
The problem is cancer doesn't know. Cancer has no pity on somebody who's low socioeconomic group,
Yeah.
Cancer wants to win the war. Okay? So it will relentlessly go after.
Yeah.
So our treatment also has to be relentless, has to be full of knowledge the very first time. And that is where the dichotomy comes, when people start thinking about cost, because we start compromising. So when we start compromising, certain section of the population will not get the same outcome when you compromise. So imagine a patient who is 30s, recently I had 4 such cases, who deserves a certain treatment. Let us say immunotherapy, which costs, and which is potentially maybe curable or long-term control. But because of either the insurance system or the patient affordability, whatever, it may cost 1 lakh per month for several months. They are unable to. Then the doctor says, okay, I cannot give, the patient refuses, whatever happens. And 2 years down the road, the patient comes back with extensive disease. The question is, who is responsible? And we can keep on debating this, we can bring it back forth. But the question is the patient responsible? Is the doctor responsible?
Or is
Or
the
is the
government
system?
system?
It's the system which
Yeah.
is preventing it.
Yeah.
Nobody is debating this. Okay? So the idea behind it should be whichever way I'm treating the affluent people, I should also bring about the same kind of treatment to everyone. Because government says that lot of people, NGOs, lot of NGOs are involved. Drug pricing. You take for example drug pricing in India. Drug pricing has been beaten down so much. The generic drugs. The drug manufacturers are saying, there's no profit in this. Why am I going to do this drug? Okay? Because everybody is obviously profit oriented. It is not philanthropy, it's not charity. They have to make their own money. They have to make their return. They look at it. It is even a new drug coming in oncology. If you take major multinational pharma companies, they go after making new drug because they see what is the profit,
Right.
what is the money. New drug comes not because of philanthropic attitude.
There's a lot of competition.
And also it is all revenue based,
Yes.
profitability.
Yeah.
They spend billions of dollars to bring a new drug.
Right.
So if they say, I want for immunotherapy, for example, people spend a lot of money. So at the end of the day, if they don't get the return, why would they go into more research?
Yeah.
So the beating down on the drug prices is also wrong. Okay, there will come a time when we can do generics. We can do. So coming back to our original discussion,
Yeah.
India can be very proud that we have great set of doctors. As you know, if you go to London, Harvey Street, or if you go to New York or Los Angeles, Chicago, any place, Houston, chances are you will end up seeing an Indian doctor. Okay, very good chance. So we are very intelligent, bright, capable in all aspects. But because of these constraints, what I told you, financial constraints, accessibility constraints, government intervention, saying that drug pricing, these are all the things. They have kind of choked the system to some extent.
Okay.
No research money.
Yeah.
In US and all, until now, a lot of money was for research. National Cancer Institute, NIH, National Health Institute, all of that. But those are very much lacking. And we are spending 1.5% of GDP.
Yeah.
Even in the budget, unfortunately, they hardly spend more. But we have all become S people. So we people ask prominent institutions, healthcare experts. Most of them say, oh, it's a great budget. But we are not also speaking loudly to make the changes in the policy. That is why I believe there absolutely need to be a policy institute for health, which we are trying to tout.
Yeah.
Under that policy institute, where we can really do a deep dive into these issues, put together data, hard facts, and take it out to the public
Yeah.
and say, look, where exactly your taxpayers' money is being spent. Because at the end of the day, money comes from a single pot. Money comes from taxpayers' money, individual. We did some calculations, almost 50% or so, then from GSTs and all that. So when you look at that total money, the pool which comes, and how it is spent, it is important to understand why healthcare is not getting that kind of priority.
Yeah.
Why is it? So we need to go into why. So anything, whether it is oncology or any of the issues and all, in my view, that why is very important. So we should go into that and see whether some of these policies can be changed. So that is where we have touted the idea of universal healthcare.
Yes. Yes.
So what is universal healthcare is essentially very affluent people, lowest of the low socioeconomic group people, farmer. You made a statement, so many are going into poverty level.
Yeah. Yeah.
Why is it they go? Because I will tell you, I'll address this issue and I'll come back to universal healthcare. Why is it? See, there are type of patient. Let us say they come to HCG. Let us say the cost is After evaluation, cost 10 lakhs, 15 lakhs. Patient, affluent patient, doesn't matter, doctor, I want the best of treatment. They can pay. Now there is second class of patient who says it's too expensive. Corporate hospital too expensive. I'll go to the government hospital.
Right.
There is oncology hospital in Bangalore, very prominent. I'll go there. Government hospital, take the treatment. Fine. There'll be some cost, but minimal.
Yeah.
Then there's a third category of person who comes to HCG. Doesn't matter. I'll borrow some money from their relatives and all that. I'll do. But even though they know they can go to see, we are not a monopoly. Private is not.
Yeah,
There are
yeah.
government institutions.
Yeah.
They can.
Yeah.
So there is no need for them to go into poverty
Yeah.
because of that.
Yeah.
Okay.
Yeah.
But there is a fourth category of person who is poor, who cannot afford and who wants to sell his property to save his spouse or somebody. When they are told, recently it happened to me, and I told the farmer, look, there is this hospital close by. Why don't you go? He said, no, sir, I want here only. So then, of course, because I was involved, I told him, you can't sell your property, do anything, borrow loan. We took a statement from him, helped him from the foundation. But that is not every patient we can do. Okay. But otherwise, the farmer would have sold his property, gone into debt and all that.
Yeah.
But this patient doesn't want to go, whatever happens. Who is responsible for this? Is the farmer responsible? Is the HCG or hospital responsible? Or is the system who is responsible? So that is why, see, these kind of instances are not properly recorded, not properly put out. We glorify great schemes and all, but people are forgetting there are lacunas, gaps, which requires a deep study. That is what our Policy Institute will do.
Yeah.
We are already doing, will continue to do, and link it to universal healthcare.
Yeah.
Suppose there is a universal healthcare for this farmer.
Yeah.
Same thing.
Yeah.
Where he is going to get, he is not going to pay anything from his pocket, but he is going to get the same treatment as the most affluent person coming to HCG.
Yeah.
Matter is solved.
Yeah.
Okay. So how do you solve this?
I believe there is no structure in place.
Yeah. How do you solve this?
Yeah.
How do you solve this is, as I always say, common sense is so uncommon. I think the great philosopher Voltaire said that. And I have always coined the word simplicity in complexity.
Yeah.
It appears very complex. I have approached government. They say, no, it's very complex. How do you bring about? But when you simplify it, it can be done.
Yeah.
So here is one example I like to give. You go to a big lecture where there is somebody, very renowned person has come to talk. You think you go to a big lecture on various aspects. There is a person who has come, talks about complicated quantum physics or something, whatever, or biology, DNA, genomics. You hardly understand most of it, but very complex. Then you come out and say, what a great lecture, man. Very complicated. I hardly understood, but what a great lecture. But on the other hand, you go to another lecture where the guy is simplified everything and gives you in simple terms the answers. You feel, why did I have to come for this simple solution all the way? But the reality is the second person knows the subject far better than the first.
Yeah.
So even in this universal healthcare, when we simplify and put it, people are not accepting it because it's too simple. But it is highly they want a complicated structure.
Yeah.
So let me explain what is this simple structure. India is full of youths. 62% or 5% are youths. Normally you don't expect youths to get cancer. So they all have cell phones. They scroll the cell phone multiple times every day.
Yeah.
Watch movies, whatever they want to watch. There is a bill which comes.
Yeah.
So all we said was add a healthcare cess based on the bill amount.
Okay.
So that cess goes to healthcare.
Okay.
And by my calculation, when you do it according to the job description and the bill, a hybrid variety, you can collect about $150 to $200 billion a year. Okay. So if only you can, there are other ways you can do GST cess, you can
Yeah,
do
yeah,
various
yeah,
things, and
yeah.
also corporate tax, you
Yeah,
can put a
yeah,
cess,
yeah.
increase the cess on cigarette,
Mm-hmm.
and increase the cess on, we can also talk about
Alcohol.
smoking and
Yeah,
all after
yeah,
alcohol,
yeah, yeah,
increase it
yeah, yeah,
by a little bit, tweak it,
yeah,
so that people may not feel the pain, at the same time it is contributing.
yeah.
With all these additions, we can generate 150, 200 billion.
Mm-hmm.
For the Indian healthcare system, economy of $4 trillion,
Mm-hmm.
200 billion is a small percentage,
Yeah,
right? You know, if
yeah.
it is 10% of 4 billion is 40
40
billion,
billion.
400 billion,
400. Yeah.
400 billion. This is 5%.
Yeah,
5% of healthcare, if you increase,
yeah.
using all this, which
Yes,
doesn't
yes,
affect your
yes.
budget, what you want to spend on defense,
Yeah,
everything. And by the way, India is the largest importer of defense.
yeah.
Importer. Why do we need that much defense? Why can't we throw some money on healthcare? But we want to. Who is the threat to us? You think today China is going to come and occupy India? No way. Why would anybody try to occupy India? Today, nobody wants land grab. Today, we want technology grab. We want economic grab.
Yeah.
Nobody wants to occupy land. Whatever Russia did in Ukraine was a different reason. But we have to understand fundamentals. We make America, Europe rich by buying equipment from them. And we become poorer. So we have to also think of it.
Yeah.
Do we need, for example, there is a country called Costa Rica in South America, which has no army at all. No army. Very prosperous. We should learn from them. How do we create peace, bring about peace, less on defense? All of that are important. But it is fashionable to spend more on defense, not on healthcare. Okay, health and education. So, if only you can spend that 200 billion.
Yeah.
And another thing we propose, this 200 billion can also be invested in markets. Like Canadian social security system, which is one of the largest in the world, invests as private equity, invests in healthcare, invests in social causes, and makes money, good returns.
Yeah.
So there's $200 billion
Yes.
but just by investing.
Right.
Just by investing.
Right.
And out of that comes taking care of healthcare. Out of that money comes, how do we pay for this? Equalizer.
Yes.
Rich, poor, everybody equalize.
Yes.
There is no limit. For example, in the scheme, oncology, if you say 5 lakhs is the limit for the whole family, and I will restrict what I pay, there is no way I can provide optimum treatment at 5 lakhs.
Yes. Yes. Yes.
No way in the world.
Yeah. Yeah.
Okay? For a disease which requires continuous care,
Yes.
monitoring,
Yes.
everything.
Yeah.
So we have to look at it in a different way. You have to make sure that it is not limited and it pays well for certain procedures, things, certain expensive drugs, targeted drugs, patented drugs, so that the patients, irrespective of their socio-economic condition, can get the optimal treatment. Because we have all the infrastructure. We have phenomenal hospitals. We have phenomenal doctors.
Right.
And we are getting great outcomes for people who can afford to pay. But why is it we are not able to do it for everybody? Because of this issue.
Right.
The gap in funding.
Right.
And the government, the system, the revenue, the budget, whoever are the thought leaders are not understanding it. They are just going after cost. They are not going after outcome. And it is a great mistake. So, as a policy institute, going back to ours, we are going to focus on that.
Yeah.
We are going to nail it down and repeatedly talk about it so we can bring about an equalizer in healthcare.
Yeah.
And the day we bring that equalizer, there will be issues. There will be constraints. Even a person who can afford will bring the card,
Yeah.
show the card and get the treatment.
Yeah.
They may pay some premium. The lower socioeconomic group may not pay any premium. And the youth who are paying the cess, important thing, when they become old, everybody is going to become old one day. As you know, aging is a natural process.
Yeah.
All the youngsters will become old. For them, it will cover when they become.
Yeah. They
So
can
they-
reap that benefit.
Yeah.
Yeah.
And another issue, which we have done as a policy institute, we're going to do is tackle the problem of prevention. Obviously, prevention is better than any cure.
Yeah.
For example, we have talked at our Antardhwani IHDUA, our NGO, about smoking, where we have taken the issue and showed in a pilot project alternate farming can actually help the farmers and reduce the tobacco usage. But the problem is giants like ITC and others are making sure the farmers continue to grow tobacco. They pay, they were not paying that much. Once we intervened, they started paying them more. So our project got jeopardized. But the most important thing for government to do is to restrict the use of tobacco or even ban. When we raise the issue in public forums, the only thing they can say is, one of the members of the parliament asked me, does smoking really cause cancer?
Yeah.
It's chewing. So what do? Second question is, lot of revenue comes from these areas. What do we do? But we can also guide them to alternate areas. Even ITC can go into alternate farming, alternate things. So they can make their money. Okay. So there are multiple issues in this society. I think the important thing here is we should see how to address each one, segment it out, and simplify. We should not become professorial.
Yes.
Economists giving a long answer. It's simple, straightforward, doable. They should put right people in place. Unfortunately, they put only government people in place. How do government doctors or administrators know what is happening in the real world? Because the type of people they are dealing with, patients are different.
The ground reality is totally different.
And then the question comes, what should be the role of government? See, this is something in the universal healthcare we are going to address as policy. There was a great thinker, philosopher, Henry David Thoreau. He said, government is the best which doesn't govern at all. It's too extreme. And then there is another great thinker who said, government is the best which counts the least. Okay? Emerson. So we should look at government should become a monitoring agency. Government should not be in service. What does that mean in healthcare or education? Hey, I have a patient who is low socioeconomic group. I'm sending the patient to you. I'm paying you equal to what you charge others. I want them to get the same outcome. I will monitor. So I monitor the patient with breast cancer or cervix cancer, make sure she gets the same outcome, same treatment. Matter is done. That is the purpose. See, I told you about the farmer who came and wanted to sell. You said 30 million go to the poverty. If government institutions are good, why would they even come to us?
Are there any other countries that operate in this model?
Brazil operates like that. European countries. US also in a modified way does that. That's all. They monitor. See, the main thing is the Medicare, Medicaid, all of their role is to monitor. Are you getting the same treatment? Are you getting the same outcome? Publish it. If your outcome is good, I audit and good. So they should be spending all their time on monitoring, auditing. Today technology is so good. You talk about digital health and all that, you can easily monitor. Then the matter is over. Then there is no need. Then there is no need. They can have major training centers like AIMS and others. Training centers they can have. But to say, I will start hospitals, I will do this, I will put up some centers there. Who is going to run? And it becomes cost. In fact, there is one paper published, government cost of running per patient is far more than private. And we are paying for it, taxpayers. So, as these are all in the policy institute, we are going to go into this. And nitty-gritties of, and also they should commit to spending the money.
Right.
Now, we found out that whatever was given for some education cess, we filed a RTI few years ago. Sita Lakshmi Rahul and all from our institute. We found out they have not even replied. RTI said, yes, the money was not used for the purpose. We don't, even today, we don't know where the money was used. Okay? So there is not, accountability is not there. You self-account yourself. Who will that be? Your government says, I'm running institution, I'm monitoring myself, man. It doesn't work. Who can monitor them? There has to be a different system. So we have to really, really address this issue in a way. And people who are decision makers have to listen to people like us. Today, nobody is listening.
Yeah.
And they are all government bodies, government from government institutions who are advisors, who have no knowledge, zero knowledge about what happens at ground zero level. Like the examples I gave you. They just say, we have Aishman scheme.
Yeah.
We have this.
Yeah.
But they don't understand it is half-baked.
Yeah.
And actually half-baked is worse than zero-baked.
Yeah. Yeah.
Okay? So we are giving false assurance to patients and false communication.
Yeah.
And patients trust the government. Okay, yeah, they are giving the scheme and all. So those are the issues. And we are giving them hope that you are going to get the right treatment. They're not.
Yeah.
So these matters have to be thoroughly discussed. And so Policy Institute of ours, we will put out papers. We will have a dynamic team working on that. And we will also do a lot of communications and see whether we can at least, and go before the parliamentary committee and see at least these issues are properly addressed. First thing is, step A, address it.
Yeah.
Go deep into it.
Yeah.
3, let us see whether we can find the credible answer.
Yeah.
These are the 3 steps we have to take.
Right. Right. Beautifully put it. Doctor, this also brings me to another inequity issue, is the gender disparity. You have also spoken about it at various instances. So, to just give you an idea, women in India face higher rates of anemia compared to global averages, and maternal mortality rates remain high in rural areas, 130 per 1 lakh live births. So even women living in rural areas often travel about 100 kilometers to access basic healthcare services. And another issue is that only 6% of doctors in rural areas are women.
Yeah.
This also limits to a lot of culturally sensitive care for female patients. Now, women is actually a backbone of a healthy and family. But why this kind of disparity is existing even now? I mean, how do we address this issue? Even in my own extended households, I have seen a lot of issues like these, where the male member of the family is given more importance, whether it is food, health, or education, but the women is not given that. Of course, in urban India, it's little getting better. But rural areas, it's still too rampant.
Yeah, it's a interesting and very important question. And to me, particularly, we have done a lot of work as a pilot project in the Gundalpet area, our NGO for last 20 years. The whole purpose of this is understanding the women issues. How do we economically improve their status, empower them? And when I started doing this in early 2000, like a mad person, I used to go and interview women. Because first of all, we need to understand the plight. See, in India, is a skewed country. We talk about, there is Indian mythology and then there is Indian history.
Yeah.
What we call as Itihasa. Mythology is Purana. In mythology, women are talked about a lot.
Yeah.
We talk about Ardhanarishwari, means have the power in the world is related to Shiva Shakti.
Yeah,
Shakti
the feminine
is,
and the masculine
feminine.
energies.
Very important.
Yeah.
And we talk about Mother Earth.
Yes.
For everything we say mother,
Yeah.
mother is so important.
Yeah.
All of mythology talks about that.
Yeah.
But when it comes to practice in Indian history, we had sati system, when the husband dies, you should also commit suicide to the level your man can marry as many women as what. We've gone through that history.
Yeah.
And women are treated certainly like a second-class citizens.
Yeah.
Human rights abuse. Even today, I just saw some data, very, very shocking data. Family abuse of women is shocking. Like people who come to work for us and do things, when you interview them, majority would have been abused by their spouses.
Yeah.
Majority. Physical abuse. So it is a major problem. And when I interviewed this woman, they said, doctor, I work 18 hours a day. I go to the farm, take food to my husband, and work with him in the farm. Women really do a lot of work. And when I come back, I eat only what is left over. After others eat, I'm the last person to eat. So they were anemics, like you said, 75% were anemic. Had vaginitis, inflammation,
Yeah.
infection.
Yeah.
So that is when we took up on this cause of self-help groups for only women. Initially, the men resisted. But through this microcredit system, just to fast forward to 2025, significant affluence has come. And women are empowered. Women are appreciated in this group what we have. Again, as Policy Institute, we are going to put out disparity. Part of it, how do you overcome disparity? Simple solutions for complicated. Just make sure economically women improve. The average income now in our target area is about 25,000 to 30,000 per month compared to 3,000, 4,000.
Right.
So all of this is very important. At that time, children, women, girls were not allowed to go to school unless they've got up in the morning, finished their work.
Right.
All of that has changed.
Right.
Because the thing is, we have to target an area and see how to change.
Right.
And use that as a area to change across. And that is not happening if you look at certain parts of even Karnataka or North India, Uttar Pradesh and all. It is even worse.
Yeah.
And naturally, the health issue will become secondary for women. Education and health will become secondary.
Yeah.
And abuse will be there. And also, women are responsible.
Do you mean it's because of the Indian psyche?
Indian psyche, for example, a woman delivers a girl.
Yeah.
Majority is like, oh, girl, disappointed. They want a boy. Okay? Very few women will be ecstatic that the girl is born. Whereas if boy is gone, oh, because it is embedded in our culture. And first of all, and also if the girl is not fair, oh, she is dark. That's another issue.
Yeah.
Racism also.
Yeah.
But so these are all embedded. Even when you look at Indian mythology, Devas are all fair. The Asuras are all dark.
I think it's because of the media. I don't think that's actually true.
No, people believe in it. People believe.
It's the way it is portrayed as well,
and
right?
Also people accept it. It is whatever the external ecosystem which is making it, it is making us to imbibe in that kind of thinking.
Sorry to go off the topic. Draupadi is actually supposed to be very dark.
Yeah.
She has Krishna Varna. But then they want to portray it as the most fairest woman.
Correct. So, other day, my daughter did the Ardhanarishwari. One of the professors in Benares, in Varanasi, came and said, oh, how can you show Shiva just dark? Shiva is very fair, she said. And something like that, because this is what history. See, we are very, we are very color conscious about gender. These are all, because of our various cultural issues and, the dowry system, which is was very prevalent, maybe not now, but in the rural areas it could be still prevalent.
Yeah.
And when you marry, the girl side has to spend all the money, not the boy side. Yeah. So that itself breeds inequality.
Yeah.
And imagine a girl, also a girl born is always told that, you are not a boy, brought up in that environment, made to feel inferior.
Right.
See, as a child, that important psychological impact is very important.
Yeah.
And prevent them from going to school or doing things or chores. Even now, when both husband and wife work in a family, in majority of them, it's the wife who comes home and I make sure the dinner is ready, takes care of kids and all that. The man doesn't participate that much. Okay, so
there's no conversation around this. I think some NGOs or some of the corporates, they do these kind of messaging where, husband also should be equally...
But we have to do a controlled trial. Yeah. That is what I hope the Policy Institute will do. We have to go control trial. We have to collect data, publish the data on all these issues.
Yeah.
Battered women is a huge problem.
Right.
Huge problem, which we don't recognize. Some of the people I see who come and work with me, do things and all, they have scars on their body, scars, beaten, burned body. Ask them, go deep and ask them, their spouses would have done that. So the tolerance of women is also very high.
Yeah.
Because of the society, they don't like to leave the spouse.
Yeah.
Lot of things. So we should interview women. We should take it up as a serious issue. Okay, that is something we have to take up. Coming back to the women health, yes, there is a major issue. For all these reasons, cultural, social issues, it has to be really addressed. I hope policy institute like us, we will really put in for an institute to succeed, you have to run it like a company. And you cannot be dependent on somebody giving you money, philanthropic money. See, in my view, the money is also an issue for all these policy institutes, NGOs to do. What has happened is you start with a cause and suddenly somebody says, I'll give you money for this and all. Your cause gets derailed. So I hope our policy institute is not going to depend that much on external funding.
Right.
It will be self-funded. And the way we do it, we have some criteria we put together. We will spend significant amount of money yearly to make sure it is well-oiled run machinery like a company where we hire right people. We also have a policy institute. People come and enroll. Maybe they pay for that to study internship programs, apprentice program. We'll generate. We'll also have a corpus. Using that, we'll address all these ills of all these disparities in society. See, women is also a disparity. Women issues are disparity.
Yeah.
Health issues are disparities. Education a disparity. Wealth is a disparity. So how do you bridge the gap is an issue. For somebody said India's GDP is 4 trillion. And it is the 4th largest, going to be 3rd or 4th largest in the world.
Yeah.
But why is still we are considered developing country? Because our per capita income. Per capita income is very low. And the disparity.
Yes.
We have 300 billionaires in India, but that they are sucking up all the money up there. Okay, so we have to address all this. It's a huge problem.
Yeah.
There are people who attempted to address, but one of the great advantage we have as our policy institute, and thanks to people who are even Sita Lakshmi, Rahul who joined.
Yeah.
As you know, Sita Lakshmi was editor of Times. Rahul was deputy editor. They're working with us. Thanks to people like them, we are one of the, and I have our NGO activity in Gundalpet, people who work there, multiple. We are one of the few institutions where we have a ground level experience at rural level. Same institution has high-end looking at a policy institute. So the raw materials comes from here, feeds to this. Using that material, we churn it, understand and put out. So we are not depending on some theory where it's not an armchair philosophy, armchair theory. Where actually practically we are learning, we'll put it to use, whether it's health, education or wealth. So we hope this will do well. And one of the things also you wanted me to address is doctors. See, one of the role of doctors, like I said, doctors are very good in India. And when you become a doctor, let us say a neurosurgeon, a oncologist, people don't understand how long their training is. 5 years, 5.5 years of basic education, MBBS, then 3 years of postgraduate, then another 3 years of super specialty. So you're talking about 11 to 12 years of your life you have spent in this training. And
practicing is later.
Practice. But most of the doctors really do not go into profession for monetary reasons. They have an inclination to be in biology. They want to study human, and also they want to think challenging. I can challenge, like in cancer field, such challenges. And we can talk about it sometime too. What are the challenges in cancer field? When you look at it, it's very interesting, research. But as they train through the system, naturally they want to have some affluence. So this media bashing on doctors are the, what is it, Narayana, something they say, you are like God and all that. So they expect doctors to not make any money and live a very altruism life of all this training, not have any aspirations. It's not possible. That's why I tell my doctors, If you drive a nice car, if you're doing good, we have no issues. And some of the doctors' salaries in India is very good. They should be paid for their training. But they should do the right treatment.
But
They
there is a being a socialistic mindset, a
Yeah.
country like India. We always, I mean, not we. I mean, there is a general notion that private hospitals
Yeah.
are there for minting profits
Yeah,
because.
but it is not true.
Hmm.
The truth of the matter is, you take, for example, HCG or some, we don't give any dividends. See, whoever is shareholder doesn't get any money. The shareholder, they buy share, they sell shares.
Yeah.
For us, when I did a talk at Harvard Business School, I gave an example. We are no different from not-for-profit.
Yeah.
Because we don't give out any money. Even non-profit pays for doctors, we pay for doctors. Non-profit pays for administrator, we pay for doctors.
Right.
Non-profit charge the patient, we also charge. So the idea should be understood by this public. This is something, again, can go deep into the discussion to see how Indian healthcare has evolved, how aspirations of the doctors should be met, doctors, why we should support, like what I call a doctorpreneur. Like my history has been like a doctor who became an entrepreneur.
Yeah.
And we all come from a very middle class family. I always say, some people are born with silver spoon, some people are married to silver spoon. We are born with aluminium spoon, only education.
Yeah.
But using that,
Yeah.
we have evolved into this level because we have a focused approach.
Yeah.
When I came back from US to see what can I do right thing for the cancer care, in healthcare disparity. But in that process, yes, finances followed, because without finances, how can you put in large technology, linear accelerators, which cost 20 crores, 15 crores? How can you put in that kind of equipments? How can you pay the whatever debt you have? All of this is very complex. The public at large may not understand, but it is a complex. And to get good talent, when a doctor is trained 10, 11 years, why would he come for a low salary? So you have to pay them right amount also. So that attract them to come there and make sure they're doing the right thing for the patient. So I think, like you said, the concept, the private hospitals are charging more and all, is totally wrong. There may be some isolated instances, but reality is, it's very important there be cross subsidy. People who can afford has to pay. When you have a very wealthy person coming or a NRI coming and all that and saying, can you give me a discount? It is not despicable. People in India, the concept is bargaining is there. For example, I'll tell you one example. I jog in Kabban Park. Okay, and one day I was jogging a few years ago. I saw these two big hefty people, speaking Hindi and arguing with a fruit seller.
Okay.
The fruit seller had legs like sticks.
Okay.
Malnourished, standing there and trying to sell some fruit, and these guys are bargaining. I went there and told them, look at you guys and look at this fruit seller. Shame on you. You are bargaining with. So where is this concept of bargain in India for everything? Everything you want to say, give me a discount, give me a this.
Yeah.
So we have to get rid of it. You go to a 5-star hotel, you don't ask for a discount.
Yeah.
You pay whatever it is.
Because there's a tag there.
Yeah. But you go to the street and the poor man is selling something, you want to discount.
That's there in the DNA.
DNA.
Yeah.
We have to get rid of that.
Yeah.
We have to be proud to say, I will pay you what you ask. Give me good stuff. See, that's all. Like that in medical also. Give me good care, good thing, I'll pay you whatever is the thing. Okay, instead of making an issue and all that. And nobody is asking you to. It's not a monopoly. If you don't want to come to me, go somewhere else. There is a hospital, you can go. Okay? Why do you come to us and complain about the charges? You come, you pay what is said. And we have to be transparent, by the way, in telling them what are your charges. That is where some problem is. If you mislead the public and say, okay, I'm going to charge you 5 lakhs instead of the bill comes to 7 lakhs, there's something wrong. Unless something goes wrong, you can explain. You can give them the whole gist of it. So these are some of the things which, from the doctor's healthcare side, has to be corrected. Proper communication, proper trust. See, where I see the problem in Indian healthcare today is the trust is not there. See, a doctor goes to a a patient comes to a doctor or a hospital. The doctor says you need a scan. The patient says, is this doctor getting some cut out of it? Is that why he is ordering? See, that thought process has come because of the way we are responsible for it. Because if the trust is there, this question wouldn't have come. Public media, all these TV media talking about it, and doctors who are also not ethical has brought this. So, see, issue is, if a doctor participates in the care of a patient, they should be paid. If the doctor is not participating in the care, they should not be. Similarly, the hospitals, similarly things, so there are some deep-rooted issues with doctors.
Yeah.
But at the end of the day, ethics is important. At the end of the day, right treatment for the patient is important. And costing should be measured in different way. We cannot say it should be low cost. And there is a cost to low cost.
Yeah.
And people who can afford to pay, there is insurance. You can buy insurance. You can cover yourself. People should look at alternate ways of making sure the cost is spread out rather than being individual. But the affording class is one of the culprits here also, bringing up cost issue and all. And we have to make sure the gap, cross subsidy should bridge the gap.
Yeah.
So even those who are not affording class get the same type of care, not subsidized care.
Yeah.
Subsidized financially doesn't mean subsidized care.
Right.
So that is the key important thing.
Right.
The subsidy should not be for care.
Yes.
So we have to see. That is what I hope our policy institute will take up seriously, and we will get the right people and drive it so that eventually we hope our policy institute, Antardhwani, inner voice, various things will make a difference to the society. But India is very vast. To make a difference across country for one policy institute is not easy. But once we create that, hopefully it will have a multiplier effect. People will take up the issues, where the money is spent properly, what is our GDP, are we spending properly, is it going to the right place, are we monitoring it properly, and based on that, are we getting a good outcome. So these are simple 1, 2, 3, 4. But as I said, simplicity is not accepted that easy. We want a complex solution that we should get away from.
That also brings me to a point where 76% of the country's healthcare needs are met by the for-profit hospitals. And that's a huge gap.
No, that is why I said for-profit hospitals are very much needed. 100% should be met by them. Government role should be monitor. Just monitor these people. Make sure you're doing the right treatment. Government should not be training. In training, they can take part and all. Government should not be in giving treatment. And that is because India has gone too far in private enterprise. There's no going back. So we have to see how to tweak the system so that the government takes control of monitoring, making sure the right things are done, and then only reimburse if the right things are done.
So do you think the think tankers at the government, whether Niti Aayog or any other organizations, are aware of this fact?
They are all loaded by government people, administrators, bureaucrats, which is a fallacy. There are no private enterprise contributors to that, very few.
Okay.
Because the way the government structured is, for example, I talked to the bureaucrat friend. Today, I am a IAS officer in charge of Metro of Bangalore. Tomorrow, I have been posted as a healthcare secretary. Tomorrow, I am become an expert and healthcare man. I am going to teach you all how to do healthcare. Day after tomorrow, I have been posted as agriculture. I know how to take. It is not going to work that way. You need technocrats, not bureaucrats. See, the entire IAS system is at fault. Great people, high IQ.
But it's flawed.
It is flawed because you expect them to be experts overnight. They cannot be. We have spent all our life in being in that. How can they become experts? The system is, and Niti Aayog is all bombarded with this. Our doctors who work in AIMS and other areas, what do they know about private enterprise? Zero. And they are telling us what to do. The system has to be dismantled and recorrected. Okay, if you really want to. You know, when the governments come by election, they say, I'm going to have less government. People make that statement. But when they come to power, they only increase the government. You see the track record of all the people. When they are up for election, they say, my role is to dismantle, make sure government is only governance and all that. But everything is government. So that has to change. And the role of bureaucrats, everything should be reorganized so that they look more at monitoring. Hey, are you doing the job correctly? Are you do? Because I am paying you for it. Because schemes, they pay, they do everything. And also unethical practices should be cut.
Yeah.
And unethical fraud, corruption. Corruption is the heart of the society now.
Yeah.
Corruption is killing us. When you see a bad road, I always tell doctors. I was giving a talk to 500 doctors, some doctors' day. So I told them, I know a lot of you don't pay proper income tax. You stuff your pillows with cash. But end of the day, you walk out on the road. If the road is bad, you have no right. If you don't pay proper income tax, you have no right to question the system. One. Okay? So if you pay proper income tax, you're doing everything. Then you have to question the system of corruption. But if the government is getting money for a road builder, why would he build a proper road? Because he has already given money. For his role is to save as money as possible and build a bad road. Compromise on the quality. That is why we have all the potholes and all.
Yeah.
But nobody is attacking that problem. See, there are two issues. One, taxpayer issue. He has to pay proper tax, question the system. Second is those who are getting the money, make sure they are not getting bribe and other things and giving it to people who are incompetent or who are compromised, so the roads are bad. Pothole. So this is what is one an example. I'm talking about everything in society is a road example.
Yeah.
So, all the things are very deep rooted. Corruption is honestly at the heart of a lot of these problems. At the heart. And everything, whatever you take, it has to be, it has to be eliminated. China, look at China. Amazing. I have not visited China. I just read. 1992, the GDP India and China were same. GDP of China today is 19 trillion. India is 4. China is now becoming amazingly advanced. Their healthcare, almost near perfect healthcare.
Yeah.
Technology, phenomenal.
Yes.
Defense growth.
Yeah.
And they're challenging. To in few years they'll be number one economy.
Yeah.
And they are challenging roads, infrastructure. Why can't we do, man? We are equally intelligent or even brighter. Why can't we do?
Yeah.
Because of all this
the political system
bureaucracy,
and,
choking, corruption.
Yeah.
China, by one shot, he eradicated corruption.